Thank you for the organizing committee to give me this opportunity. I'm a nurse. I've been working in hepatitis for a long time and hepatology for a long time. And I'm soon at the end of my career, and this is a really fun time right now in liver disease. I can honestly say that. So let's go through slides. So I really don't have much to disclose, but I've done consultation for AbbVie. Not a whole lot of other people. And there's nothing off-label in this discussion or this presentation. So, letting you know. So, I am also a member of the Canadian Association for Hepatology Nurses, and my colleagues are in the room. And thank you for coming too. So, just so you know who we are a national organization. We stretch all the way from Newfoundland, so St. John's, all the way to Vancouver and Vancouver Island. And up north, thank you for coming, Hélène. So, Helena's from the Northwest Territories. So we actually undertook a survey within the last year, and it was presented at the AASLD meeting. But I really want to point out a few really important things. Our group is also aging, so we need some young people to work in this area. 35% of our nurses have salary support from industry right now. We have to wonder about, is that sustainable? And 60% of our group are worried about job security and potential sustainability as our role in delivering care for liver disease patients. But we're very optimistic, as nurses always are. We always find humor and joy in many things. And we acknowledge the challenges, and we're ready to face them. So, over the last number of years, you can see the treatment cascade. Everybody knows this. You know, we have lots of people with HepC, very few get diagnosed, very few get into care, and very few ever got treated in the old interferon-based treatment. The big arrow is where a lot of our nurses originally started from, is when we were doing the interferon. And we were treating a very small number of patients, but it was very intense. Very intense. We are now getting more of our nurses involved in areas where I think we've heard a lot about today. Working with those who are marginalized, getting them into care, and hepatitis C is just one of the things to bring you into care. You have lots of other health issues and mental health issues and social issues, but this is just one thing to start you getting better on and working on your determinants of health. When I first came with interferon, and it was a long time ago, it was onerous, cumbersome, fraught with issues. There were more reasons not to treat people than there were to treat people, because you could always find a reason. If you really, people would say, oh no, not the right. And there were lots of competing priorities for our patients. And we've heard that because we as nurses have done that work with Gail Butt in the BC CDC about why patients wait for treatment. It is competing priorities, and we also heard that this afternoon in the presentation from our Aboriginals. So there are many things. It was long, multiple side effects. It was very expensive. You had to have lots of blood. You had to come in for appointments. Lots of people don't like coming in for appointments. The parking is too expensive, et cetera, et cetera. But because of this work, the development of nursing roles, so there became a hepatitis nurse specialist whose primary role was in education, support, dealing with treatment side effects, monitoring. We expanded that so that now in Con, we even have a lot of people who work in primary care, work with the marginalized, and with addictions. And we also have nurse practitioners in Canada who are also prescribing treatment for hepatitis C and who are involved in provision of care. But we have a new reality, and the new reality is shorter duration of therapy. And these have a lot of opportunity to facilitate really good health outcomes. They're well tolerated, they're fixed dose combination, there's a lot less pre-treatment workup. Many of us nurses know what the workup was for telaprevir and boceprevir. It was a lot of extra work. And you potentially can think about decentralizing care to different peripheral facilities and using non-specialized physicians one day to provide this care. I live in Halifax, Nova Scotia, and we are using non-specialized physicians to help provide some of this care. So even us in what I consider sometimes not Toronto or not the big center, but we're trying. So this is where I see us having nurses. This is a model we're all aware of from the United States, but we need nurses to help with improved diagnosis. There's no use having all these wonderful medications if we don't give them to the right people at the right time. So we need nurses in an upstream. In the prevention part, where we heard today that opiate substitute replacement as well as needle exchange can help. But we also need to get those patients identified and get them tested on an ongoing basis. Point of care testing. I know people in Saskatchewan have been working with point of care testing, blood spot testing, done with nurses in clinics where they are. We need to develop standard algorithms for people with using in addictions, sex trade workers, mental health, prisons, all kinds of things. And one day maybe we will have guidelines that look at baby boomer testing as well. Okay, so I got 2 minutes. So what I'm going to do is tell you what we have. We have a bad model of care right now where basically it's all siloed. Care is siloed, right? So where I see it going is we get a different care model. And I'm going straight to the back of this. Forget this, forget this, forget this. Go to the last one. So that's it, so that's it. So look, this is a care paradigm that I see, where you could even have it provincial, you could have it in your hospital, you could have it in your community. But where there are stars or where there are going to be nurses, because we're a little bit starry, but you have them at different points, access for finding about diagnosis, helping and determining in education and treatment. Doesn't matter where, and you'll need them for treatment, at least getting started on treatment. We don't have to chase around as much for terms of blood draws and things like that. But also the other thing is many of our nurses are going to be involved with the other part of hepatology care of the individuals who have more advanced liver disease. Whether that be done in primary care, which I think some of it will be, tertiary care and quaternary care, of course, for those patients who will go for transplant. But really, the role of the nurse is actually going to be more expanded in the areas of population where we heard we can make a difference, where we are needed, and where we need to have a lot more organized and upstream approach. So more in depth there. Anyway, that's it for me.